Really pleased today that we have Dr. Bryan Burke speaking to us on autism and telehealth. Dr. Burke is a professor of pediatrics and neonatology at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital, and has been very active in developing telemedicine techniques across a variety of disciplines. He's active with the AAP section on telemedicine, and some of the folks across our network may recall that he presented at one of our annual network meetings a few years ago and continues to do a lot of groundbreaking work in this area. So I'm going to turn things over now to Dr. Burke.
Well, thank you. And thank you to all the Autism Network for asking me to do this webinar. I come to you with only 17 slides. That's intentional for at least a couple of reasons. One, I think we can get what needs to be communicated, what I think it is that you want to hear about by just using 17 slides. The second thing is that I very much like for lectures to be interactive. You do not need to feel the need to wait until the end of this presentation to ask your questions. If you have a question at any what time and along the way, then simply ask it. And with only 17 slides in an hour's time, I think we can take our time and discuss any points that you want to have discussed. And if we get out a little bit early, I don't think anyone ever minds. On my slide, it says I'm a professor of general pediatrics and neonatology. That's a little confusing. I am a general pediatrician. And for the last 10 years, I have had a half-time position in the section of neonatology at the University of Arkansas and a half-time position in telemedicine. I take care of the term nursery and some of the sick babies, but not sick enough to need the respirator. And I have a group of peers, other general pediatricians, about 8 of us who do the same thing. So if we can go on to the next slide. All right, if you'll just have the 3 bullet points. The first one's there. I have nothing to disclose. I did choose these pictures intentionally. The one on the left at the top is Shylock, and of course every lecture should have some sort of classical reference, but all 4 of these represent greed. The top right you have Scrooge, and since we're going to be discussing how to take care of Tiny Tim and his autism problems today, I thought that might be appropriate. I have Mr. Potter down in the left-hand corner, and of course we're supposed to take care of the whole family too, which he tried to mess up, turning the town into Pottersville. And then I have Gordon Gecko in the bottom right corner, chosen not just for greed, but because the first cell phone that I ever saw and the technology behind that, which has evolved into the technology that allows us to practice telemedicine, was in the movie Wall Street in 1987. That's not the cell phone itself. I couldn't find that picture. That one has the old landline. Next slide, please. All right, there are 4 basic ways to use telemedicine, and I think this is an important slide because telemedicine can sometimes feel, if you're not used to it, like a bright, shiny object that looks kind of cool, but you're not sure what you're supposed to do with it. The first way, and the part of telemedicine in which I am so actively involved, is tele-education. And we're going to be talking about tele-education and how we can educate the parents and the other caregivers of the child on how they can take care of a child with autism. And we'll also be discussing to some degree how you can use the tools of telemedicine as the autism and developmental specialist that you are to educate the docs in private and community practice on how they can better take care of children with autism and educate them in that way. Next little picture, please. This would be like the next bullet point. Here we go, teleconsultation. Now, teleconsultation is what is used when someone out in a more rural area typically needs help from someone in a medical center. It's an easier thing to think of if you have a child with a 40% body burn that rolls into a small town ER and they haven't seen anybody with that kind of a problem, and you need a pediatric intensivist or you need a pediatric ER doctor, but it can also be used in situations that aren't life-threatening, like all the type of behavioral problems and specifically autism, where the doctor in private practice can link with you, and whether he's doing that simply to talk to you or whether he has the patient in his office and he is showing the patient to you, that is a teleconsultation. Next picture, please. And telepractice is using telemedicine to take care of your own patients. If you are a general pediatrician in practice, you can use this to gain access to your patients wherever they are. They can be in daycares, they can be in nurseries, they can be in preschools or grammar school or high school or college, or even juvenile detention facilities, or even, God forbid, prison, or wherever they happen to be. They may simply be on vacation at Disney World, but you can take care of your patients and keep them in their own medical home to where they don't have to go to an ER and see someone that they don't know, who has no idea of family dynamics or the specific features of the child's illness and underlying health. Next picture, please. And then there's tele-research, which can be subdivided into three categories, and this might be more interesting to you all than it is to most groups. The forms of research are simply researching the effectiveness of telehealth itself, which wouldn't be of such great interest to you. What might be of more interest to you is the dissemination of translational research. I'm going to tell you about an educational program that we have at Arkansas Children's Hospital that part of what we use the program for is to disseminate the findings of the translational research done on our campus, which our researchers tell me is a really great thing to be able to put on their grant applications, that they have a network that goes throughout the state and a little bit into some surrounding states to disseminate the results of their research. And the third way that you can do tele-research is if you are researching something that doesn't happen very often, perhaps something like connective tissue diseases of the heart. And there may not be enough cases, unless you live in an extraordinarily populated area, to have enough cases to do research. So you can really reach out to people at any institution anywhere in the country and anywhere in the world as a means of expanding the number of patients that you can study. Let's go to the next slide, please. There are a number of tele-education examples. We can go through, there's 5 or 6 bullet points that we can go through fairly quickly. Web-based instructional videos like on Blackboard. Next one, please. Second Life, which is a virtual didactic experience. Third point. Text messaging for patient education. I'm sure a lot of you have been exposed to that. You can remind patients to take their medicines or to come in for their immunizations. Surgical and procedural skill instruction. This is used particularly in reaching out to third world countries where you're trying to teach people a new procedure or something, and you might not want to necessarily hook up from Little Rock to Fayetteville to do something like that when it's so easy to get down to Little Rock for that type of thing. But when you have no other way to get the education to them, it can be a very valuable tool. Next point, please. And you can do simultaneous web and video conference transmission with archiving. And then the last point, please. And you can do live interaction, completely live AV, a real-time interaction. Next slide, please. Now, we started Peds Place in Arkansas in 2007. The PLACE stands for Physician Learning and Collaborative Education. And the collaborative is terribly important because we think the people in private practice are just as bright and just as energetic and hardworking as anybody that we might have in academia, and the knowledge flows in both directions. I practiced in rural Arkansas for a number of years, so I have a special passion for that, and I'm something of a Johnny-come-lately academician. Next point, please. We also wanted to build relationships between the practitioners and the subspecialists. It is frustrating, even for me at Arkansas Children's Hospital, to be able to keep up with all the people who come and go among our faculty. And to think that somebody in private or community practice could keep up with who everyone is, it's a virtual impossibility. And also it's very helpful for the subspecialists if they are able to see the person who sent them the letter of referral and get to know them on at least some level by working in a completely AV interactive fashion. Next point, please. I made this point. We believe that learning comes from the practitioners. I believe I learned at least as much from people in private practice who link with us as we may ever learn from them. They keep us grounded in reality and ask questions like, well, what do you do if you don't have 24-hour-a-day access to bedside ultrasound? And things that are quite pertinent and important. Next point, please. And I've talked about the dissemination of translational research. We can go to the next point. And we believe that by learning from each other that we're going to improve the health of Arkansas children. I see it happen all the time when perhaps a doctor in El Dorado, Arkansas will say, this is how we deal with that. And then you'll get to see the doctor in Jonesboro kind of look and say, wonder how that would work in Jonesboro. And he'll take a good idea that he would not have otherwise known and incorporate it in his practice. And we do the same thing in academia at ACH. I believe we'll go to the next slide now. And I just throw this picture in here to give you a better idea of what Peds Place is like. On the screen, you'll see Dr. Perry Wilbur. He is in solo pediatric practice in Mountain Home, Arkansas, and he is presenting a case to us at the time that was an unknown to everybody except Perry and me. I am the fellow sitting down at the front of the room in the red shirt looking up at the screen. Perry had a child present to him with Kawasaki syndrome. And what we were able to do, I guess I should explain the rest of the picture. These are the residents and students and fellows that attend Peds Place each week. We get a pretty good turnout because we give them free food. The part of the room that you can't see on what would be the left part of your screen are where the attendings typically sit. It's as bad as church with everybody getting their own pew and that type of thing. But what Perry's doing, he's presenting this case of Kawasaki syndrome as an unknown. Now, we could have gotten our own faculty, and in fact, it's what we normally do. We do Peds Place every week, so there's a few vacations and this, that, and the other, but I think it ends up being 47 times a year. And I would say 30 to 35 of them are done by our own faculty. But I happen to know Stanford Schulman at Northwestern, and he's sort of the godfather of everything Kawasaki in America. And so we linked with Dr. Schulman, and he would, I couldn't show both pictures at the same time, but he would come on and function as our expert when we had questions. And it's just a fascinating way to deliver education. Our residents and students love it. They think that it's very clinically based. The guys in private practice love it. We do it at lunchtime, so they're going to be sitting down to eat their lunch anyway if they're not having to catch up on their medical records. And so while they're eating lunch, they can talk to the person in Arkansas who is supposed to know the most about the topic, or indeed with the person anywhere in the world. We've even linked with 4 foreign countries. You know, you need to go to Puerto Rico or something if you want to learn about dengue fever. And so we've done things like that. and we can bring in the best people in the world. And I just love the idea that here's my friend in solo practice, the type of person that I think are the real heroes of medical care and don't get enough help. In fact, if you get me on my soapbox, I'll tell you that I think doctors who practice in that type of area or who practice in parts of our great cities that are not good to live in, by most people's standards, I think we ought to pay them more than we pay folks of us who practice in nicer areas. But at any rate, I love the idea that he can sit down, eat his lunch, get free CME, talk to the best docs in Arkansas or literally anywhere that we happen to link with, and then go see the next patient of the day. When I was in private practice, I would have killed for an opportunity like this. And just to give you an example from your own network, we're going to have Jim Farron linking with us at Peds Place. We always do it on Thursday at noon, so 2 days from now. And he'll be talking to us about his recent article that he was the lead author for in pediatrics on disability for older children who have developmental problems. So just to give you a visual image of what pediatric or what teleeducation can look like. Next slide, please. Let's go to our first bullet point. Autism has been used to teach parents about autism. You can do that through web-based tutorials that have the advantage of being always available, and so they fit into the parent's schedule for any time of day. And you can, of course, you can also do it through face-to-face training. Next slide, please. Our next point, rather. Virtual patient technology can teach lots of what you need to know about patient encounter skills, and it's not limited to autism. The next slide, please. Our next point, please. And echoing the Project ECHO that was done, I think in New Mexico, where an internal medicine hepatitis C infectious disease specialist taught physicians throughout New Mexico how to care for patients with hepatitis C so that they could gain access to their care more easily in terms of geography, more quickly in terms of getting an appointment, and still get excellent quality care. And those same people that he had trained could link with him if they had a problem that they did not know what to do with. This ECHO model can be used for any sort of disease like that, and certainly autism gives us that opportunity. Next slide, please. And when you go to do teleeducation, you know, what tools do you need? Well, if you're going to do archive things like what the patient can gain access to at any time, then all that they really need is a computer with speakers and almost any sort of internet connection. So many of our patients already have that there's just nothing to it at all. Next sort of bullet point, next picture, please. Now you can do live streaming, and that's sort of what we're doing right now. We do live streaming when we do Peds Place too. We like to do, perhaps I should have explained better, we like to do the live AV interaction so that when the doctor in Stuttgart speaks, everyone who is linked to him, wherever the link is instantly seeing the doctor in Stuttgart. And then when another pediatrician, perhaps she speaks up in Texarkana, Arkansas, the cameras go to them. With live streaming, you don't have to just see the slides. You can see the slides and the speaker at the same time, though the speaker can't see you and read your body language and that type of thing. And then the next little red bar, please. And this is what we do with Peds Place. It's completely interactive. You need a little bit better internet connection when you're going to do the streaming. And you may need a little bit better internet connection yet when you go to do the interaction. Let's go to the next slide, please. The only thing that you need more with the interactive than you do with the streaming is simply a webcam put on the top of your computer and those things are like $40. You can use a video conference unit if you want to, but really any computer will work, and it allows for real-time face-to-face communication. Now, all of us with grandkids are used to doing this and talking to our grandkids, but when you have a big network and you may have people, a number of people linked in, the technology and the IT support gets a little harder to coordinate. Next slide, please. And that's what this slide is for, not just for training, but for support, because things go wrong. No matter how hard the people work to make the computers reliable, things will go down on you. And so you have to have reliable contact information and somebody that you can get a hold of right now, just as quickly as you need to make a phone call. And you don't need to be going through voice trees or anything like that. You need to be able to get a human being that can get online with you and solve your problem right now. And of course, the online can be synchronous or asynchronous. And most of these businesses have a training center that they can send you through and help you understand the technology. And if your IT people don't have experience with it, help your own IT people gain knowledge about what they need to know to be able to help you. Next slide, please. Well, how about teleconsultation? You know, we talked about that where the doc in private practice is reaching out to you. We also gave an example of teleconsultation in an acute setting. Next point, please. Well, teleconsultation has been proven to work well in behavioral and developmental and psychiatric settings. In fact, it's really quite interesting. Telemedicine, a word I prefer to telehealth. I just think it's a prettier word. Some people want to make it, the old definition of telemedicine was that it was simply taking care of a sick and afflicted at a distance, and telehealth had a broader definition encompassing things like disaster response and that type of thing. I just think telehealth is an ugly word, so I prefer telemedicine, but be that as it may. It's actually been proven to be equivalent in almost every setting, but where it's actually superior is in a psychiatric setting. Psychiatric care, and I don't know how well this would translate to behavioral and developmental care, but psychiatric care seems to work better through telemedicine than it does in person. And that's interesting. No one knows the real answer for that. People have thought that perhaps people who need that type of psychiatric care, at least some of them might be intimidated to be in the same room with the psychiatrist, and being able to have the distance created by the intellectual distance, if you will, created by the virtual link, does something to make the advice more likely to be taken. At any rate, it works extremely well in that setting. Next slide, please. Well, a tool's needed again, and that's what's so great both about teleeducation and teleconsultation, when you don't need to really physically examine the patient, when you don't need to look in their throat, and you don't need to see their skin rash, and you don't need to look at their tympanic membrane or their retina. You don't have to have really the fancy equipment. With teleconsultation, you need a little bit of an upgrade. The picture quality, you may need a little bit better bandwidth, and I don't speak computerese that well, so you'll just have to, this is what my IT guys told me, but what you really need to have is an encrypted software. And people don't understand, or at least a lot of people don't understand, that when you're doing something like FaceTime, you're not encrypted. And if I were famous and somebody wanted to know what I was saying to my grandkids or something, and they had the IT skill and desire, they could tap into my video recording and post it on the internet and do whatever they wanted to with it. Now, if I was an important, a famous figure in the movies or sports or politics or something like that, then that would become more important, even in a non-medical setting. But in a medical setting, you're going to be saying things about people that they may not want known to the general world. And so it absolutely must be encrypted, and it has to be encrypted on both ends. Now, fortunately, that's not complicated or expensive. It's a one-time fee of around $200, and then once you're encrypted, you're good to go, and it's not a per monthly fee. Next slide, please. Excuse me, I'm about to sneeze. Pardon me if I do. Well, what are the barriers to telehealth and telemedical care? Well, one of the first ones is reimbursement. I got interested in telemedicine in 2005 when I was asked to become a part of it. And reimbursement has improved greatly. I can tell you the Arkansas experience, we've had reimbursement through Medicare, or rather Medicaid, for a number of years. But it was only in January of this year that the private insurances were required to pay for telemedical care. And if your care isn't being paid for, then it's a complete non-starter. If you're in an academic center, your academic center probably can't afford to deliver too much non-paid care. And if you're in practice and you need to keep the lights on and pay the bills, then obviously you have to get paid. The best way for finding out about payment is to go to the website of the Center for Telehealth and E-Law, and they keep a running list of the different states and what each state will pay for. Some states, Alaska is perhaps the most enlightened, and you can understand why it would be such incredible distances to cover and so few physicians to cover it that they have to use the tools of telehealth. And then other states, it's just taken on a case-by-case basis. Credentialing won't be a big deal for you guys, I don't think, because credentialing is mostly a problem for my neonatologist friends who do their neonatal consults. Even though JACO and CME have agreed, JACO and I'm forgetting it's not CME. I'm forgetting the acronym, the three-letter acronym. But at any rate, the two organizations agreed that if you were credentialed in one JACO-approved hospital, then you're credentialed in all JACO-approved hospitals. But unfortunately, the hospitals don't always agree, and that's been our experience in Arkansas, and that's been an experience of many people in different states. And if the hospital in Jonesboro says you're not credentialed, you're not credentialed. And so regardless of what JACO or anyone else says. And so you have to go about getting yourself credentialed in all the different hospitals, and that's a bureaucratic hassle. But since most of your care will be to doctors' offices or to the patient's home, I don't think credentialing will be a big issue. Licensing could be a very big issue for you, especially if you're located in a state near a border. And there's been advances made in it. There's a compact that has come along that has made licensing become more easy. But the last time that I checked, only 22 states had agreed to that compact. So again, that's if you're on the border of Kentucky and Tennessee, and Kentucky agrees to the compact but Tennessee doesn't, then you have to go get yourself formally licensed, and that has to be inquired about in every state in which you want to practice. And next bullet point, please. And then the medical legal barriers. When we were writing the technical report, the COM-LRM, I don't remember what the acronym stands for, but it's the MD lawyers who are working with the American Academy of Pediatrics were a great help in writing all the medical legal barriers. But as is the understandable orientation of lawyers, they had to put down everything in the world that might possibly be a problem, from loss of internet connection to consent to privacy and HIPAA compliance, and all those things have varying degrees of importance. And everyone always talks about the medical legal barriers. I personally think, and we were allowed to put this in the technical report, that telemedicine is going to decrease our liability. If you've ever been in practice and a mother is calling you because Johnny's breathing hard, and you're trying to interpret that over the phone, even if you didn't have access to a stethoscope, if you could just have Mama point the phone camera at Johnny so you could see him breathe and see if he's retracting and what type of air hunger he had, it would be a much more accurate way to get a gestalt for how sick Johnny is. And I think the advantages of the visual part of the inspection, and then of course, if you can, and it's being worked on for about the $200 price range, where you can actually see kids' ears and listen to their hearts and lungs, look at their throats and that type of thing, then my own opinion, and it's not worth much of anything, but if you follow my reasoning, I think it's going to decrease our medical legal risk. There's also a medical legal risk, interestingly enough. I don't know if the lawsuits have been successful, but it was either in New Mexico or Arizona. A lawsuit was brought because the ER doctor did not use telemedicine when he had it available to him, and the person had a bad outcome, and the basis of the suit is they would have gotten better care more quickly and had a better outcome if they had used telemedicine. So the knife cuts both ways. And let's go to the next slide, please. And then the advantages of telehealth. Well, and this one, you know, being born and raised in a town with all single-story structures and in a rural area, even though my parents had white-collar jobs, I have a real passion for wanting to get those kids access to care. It's a bit dramatic, but it's I don't think quite melodramatic. I think it's not melodramatic because it's accurate, but one of our physicians at Arkansas said nobody should die because of where they live, and that's so very true. And using telemedicine, you can get the care to them more quickly. The same thing goes for the inner city, though. If you don't have a car and you live in the city with a population of the millions and you have to transfer a bus 2 times, it can take as long to get from the part of the city that you live in to the medical center as it can to get from far south Arkansas to Little Rock. And then the enhancement of the medical home. If you do engage in telepractice, and there are some great groups out in the country that are doing that. Neil Herendeen and his group at Golisano Children's Hospital in Rochester have a wonderful model for how it can be done, and not just an academic model, but incorporating docs in private practice who are seeing their own patients and keeping them in school, keeping them in the daycare, and the parents don't have to take off from school, from work, to go get their kids at school, and they don't have to see a different doctor, and then a record doesn't get set in. It keeps the kid in his medical home, seeing the doctor that the child knows. Next point, please. More rapid consultation. This is more, from your standpoint, my mind tends to wander to the dramatic examples where somebody calls you because the child is gravely ill and perhaps septic, and you'll see the video where they say, is the capillary refill good? And the doctor will say, I think so. And then somebody will squeeze the patient's finger and you'll see the capillary refill is 4 seconds. Well, if you waited for 45 minutes or an hour for the chopper to get there, then find out that the capillary refill wasn't where you wanted it to be, you could have addressed that so much more quickly. And I am not saying anything bad about the person in private practice. I have been the person in private practice. And when it's 2 in the morning and you're the only person in the hospital and the orders have to be written and the family's got to be talked to and everything has to be communicated to the nurses, and then you have to call the consultant and get them on the phone and do all the things that you have to do when you're the only person in the room that can make those kind of decisions. Sometimes you can't do everything all at once, and things aren't addressed as quickly as you want it to be done. Next point, please. Well, in fact, you can go to the next point, but staying on more rapid consultation. Things can happen for you if you have your clinic set up this way. You know that there's a patient who lives 2 hours from you that wants a consultation, and your next appointment is in 2 months. Well, you can keep them on cancellation list. And if you find out that your appointment for the next day has been canceled at 2 o'clock, you can see them, you can slip them into that slot and go into the room that you have equipped for telemedicine and see them in that 2 o'clock slot where you would have had a no-show. So they get more rapid consultation just in getting their child seen, whether they have a life-threatening illness or not. Improved quality of care, we've talked about that. Next point. And for the patient, the advantages are huge. There's less travel, less expense, easier scheduling, less time off work. And you know, in Arkansas, 65 to 70% of our children qualify for Medicaid. And so the biggest majority of patients that are seen at our children's hospital have parents who either don't have work and don't have cars and money, or they have an hourly job, and if they miss it more than once or twice, they get themselves fired. And so if they want to come from Jonesboro, Arkansas down to Little Rock, they have to drive 2 hours, they have to take the time off of work, they have to risk getting fired, they have to pay for the gasoline, they have to pay for the food. I'm also Medicaid certified for every state that's contiguous up to Arkansas. There's 6 of them: Texas, Oklahoma, Missouri, Tennessee, Mississippi, and Louisiana. And if you happen to live near the Arkansas border of one of those 6 states, you can be coming to Little Rock too, and then the time to drive can be 3 or 4 hours, and depending on how complicated the problem your child has, you may be staying overnight in Little Rock, and the money, it just keeps on adding up, and the inconvenience, and of course the no-show rate, because you know, if you wish to have a high no-show rate, then what you need to do are make sure your patients are located just as far geographically from you as you can get them, and then make sure in a time sense that you have them scheduled so far into the future that they're more likely to forget they even have an appointment. Next point, please. And then you think about the challenges of a technology-dependent child. What if you have a child on a vent that has to be moved? And how, or even if you just have a child with a feeding tube or something of that nature, transporting them, maybe they just need a vent at night, and if you could leave the hospital in the morning and be back by bedtime, you could hook them back to their ventilator and they could breathe out of their trach during the day. But you know, I know what it's like just to transport children and grandchildren and get all the appropriate things that they need for their diapers and wipes and everything. And I can't, never having lived that type of life, I can't even begin to imagine that. Next slide, please. And again, increasing subspecialist efficiency. And it's not just by slipping them into your slots, but we have a huge program in Arkansas where we send physicians to various cities located in other areas of the state so that our cardiologists are going to Fayetteville or wherever it is that they're going. Well, there's a good point to that, because you get to meet people on the ground and the nurses there, and telemedicine is a wonderful thing, but it doesn't replace the in-person visit. But there are many times that you can, you know, if you're going to Fayetteville 4 times a month with your cardiology clinic, why can't you just go once a month and replace and still have those human connections, but replace 3 of those visits? What's the subspecialist doing while he's traveling to Fayetteville? And couldn't he be writing an article or seeing patients or doing something that would be productive? And, you know, it's terrible to think about, but we all will see, you know, every year or so you'll see that a chopper went down or something happened where somebody died while they were driving. And how would you feel if the head of your endocrine section died driving to Fayetteville when they did not need to do so? So there's a number of ways that you can think about it in terms of efficiency. Next point, please. And it increased patient and provider satisfaction. The patients just absolutely love the experience of telemedicine. Virtually every subjective, would you want to use telemedicine again, they just, you know, shout glory, and yes, this was the best thing since sliced bread. And you know, you can imagine yourself, you're a poor person in a rural part of the state, and you don't know your way around Little Rock, and you know, and Little Rock is just an average size, decent little city. You know, maybe, I don't know, 300,000-400,000 people, something like that. But if you're in rural Illinois and you have to penetrate Chicago, then God help you if you're not used to doing that type of thing. So the idea that they can get care and not have to go in and do that type of thing is amazing. And then the provider satisfaction. When you realize that you're not making the trips, when you realize that your patients are happier and you're seeing them more often and you don't have as big a no-show rate, and that you can see patients just as efficiently through telemedicine, and you can schedule one patient at 9 o'clock to be seen in your office, and at 9:30 you can go into the telemedicine room and see the next patient, and at 10 o'clock you can go into the next room and see a patient locally. Doctors who use it really tend to enjoy it too. Decreased time away from school, we've touched on that. Insurers tend to love it from the standpoint of decreased time away from school, because, you know, Johnny's got head lice, and so the school wants to send him home. But if you link with the school, if you're doing your telepractice and you say, yes, Johnny does have head lice, that's not a reason to send him home from school. The parents don't need to come. I'm calling the pharmacy that has an agreement with the school, and they will bring the medicine in for Johnny, and Johnny can either take it home in his backpack, or when mom and dad picks him up from school. Then when he gets picked up from school, of course, if you didn't have that system, you have to have an excuse to get back in the next day, don't you? And you can't get into the private doc's office before 5 o'clock, so you end up going to the ER and paying 10 times as much as what you would have paid if you had done it in the doctor's office, or if you had done it through a telemedical link. Next point, please. And parents love it because it's decreased time away from work. And if you're, like I say, the people who are paid hourly, they lose money, they risk being fired. If you're in a position like we have, where people are more understanding that you can take off from work, then that's not such a big deal. But, you know, the University of Arkansas wants me doing something during the day, and if I am away picking up my kid from school for a completely unnecessary reason, well, you know, what employer is going to like that? So the parents enjoy not having to leave work, and their employers appreciate it too. Next point. And then you do it, because I almost hate to put this point on here, because I do telemedicine and I'm an advocate for telehealth because I believe that it's the right thing to do for children. I have yet to see any type of medical care, no matter how excellent it is, that I don't think would not be improved if you add telehealth to it. Telehealth and telemedicine are not replacements for in-person care, but they're a little bit like table salt. They just add a certain spice to it and make everything that you're doing a little bit better than what you were doing beforehand. At the same time, if you do the right thing and you do get some selfish gratification out of it, your lines of referral, the docs appreciate that you're giving them the education, the docs appreciate that you're doing the consultations for them, and so you can at least keep what you've got. And hopefully, if the fellow next to you is not doing telemedicine and other people are satisfied and the word gets around, you'll actually increase your market share. And there are articles out there that show that that happens. Next point or slide, please. And the reduction of healthcare costs. We all believe that more timely diagnosis, fewer no-shows, getting prescriptions to people, and having them take it, educating them about their care so that they take care of themselves better, whether it's in dealing with their challenges with autism or whether it's in taking their anti-inflammatory medicine for their asthma, is going to reduce healthcare costs. And kind of depends on which way you're looking at it. From the patient's perspective, it's a huge decrease in costs for all the reasons that we talked about, whether it's transportation or taking off work or anything of that nature. From our standpoint, the costs are a little bit more difficult to prove. Again, if you're not traveling to your regional clinic, then you are able to do something productive back on the home front. If you are able to keep a kid from going to the emergency room and give him his care in his medical home, then that's definitely been proven to decrease costs. If you're able to do more reliable follow-up and diagnose a child with ADHD and they don't come into the office but as regularly, or they can't come into the office, but you can talk to them at home and go over how they're doing with their ADHD and see them in that fashion, then all of these things we believe in the data that we have, which isn't enough, but the data we have points that it will be cost saving. Next page, please. And this is just go to the picture here. This is just an interesting slide. I love anything to do with science fiction. And there was a magazine from the 1920s called Astounding Stories. And Hugo Gernsback was the editor of Astounding Stories. And in fact, the Hugo Awards that are given out each year to the best science fiction story are named in his honor. And in 1925, he put into one of his magazines the Teledactyl. And you can see it's diagnosis by radio. And he's even ahead of where we are right now, because he's using an instrument to actually palpate the patient at a distance. Therefore, the dactyl part of the word that's being worked on, but it's not here yet. It is only a research tool. Next slide, please. And of course, Solomon was right, because there's nothing new under the sun. And the Teledactyl setup, he imagined exactly what we would be doing, those of us who do any sort of telemedicine, and how it was going to work and the links that would be made. And I just find it fascinating to think that about 100 years ago, Hugo already had this figured out. Next page, please. And then this is the summary. I truly do believe that telemedicine and telehealth are astounding, and they can benefit everyone, from the elderly. One of my favorite programs that I've heard of is a program in North Dakota where they get snow occasionally. And the center that I was at has this program where they link with all wound care clinics, that links with many of the nursing homes in North Dakota within a couple of 100 miles. And these people need to have their wounds looked at every week, don't they? And so they're loaded up into the ambulance and they're taken to the wound clinic, and they're elderly and they're disoriented and they get fatigued just by getting into the chair from off the bed, and then you transport them 100 to 200 miles in both directions. And what they do is they just link with telemedicine and look at the person's bedsore or whatever problem it is that they happen to have. They get to stay in their own bed. The wound specialist says, well, you need to put Silvadene on it or whatever it is that you happen to do. And they don't have to be transported anywhere, which I think is utterly astounding. I came into telemedicine at about the age of 50. And, you know, when you get to 50, you think that there will be surprises. Some kid's going to come in and it's going to have ornithine transcarbamylase deficiency or something you've never seen before. But you sort of do get to the point where you think, you know, I've seen most of what I'm going to see. And when I discovered telemedicine, for me, it was just a revelation as to what it could do. Next point, please. And I do think it's limited chiefly to our nations. Another way, one of the most imaginative programs that we have at Arkansas is done by our obstetricians. We have a contract to deliver every pregnant lady in the state that is in prison. And of course, they have to have their prenatal care, don't they? But you just can't stick them on the Medicaid bus because being in prison, you know, folks don't like to be in prison, so they may get off the bus and leave. And so you have to send somebody with them that carries a gun and is trained in law enforcement. So it's expensive to transport them up for their prenatal visits. They do all their prenatal visits by telemedicine. They even have their pap smears and their colposcopy and everything done by telemedicine. And our obstetricians are picking up cervical cancer and vulvar cancer at a distance. And the only time they come to the University of Arkansas is when they go into labor. I just think that's a great example of how you can use telemedicine to solve a problem if you just have enough imagination. Next point. It's going to become commonplace. One of the questions I asked my residents before I start talking to them about telemedicine is, I'll say, I went into practice in 1982, and the day before I would be on call, I tried to collect as much change, as many coins as I could, and I asked them if they know why I did that. And it is only the infrequent resident or student who can answer that question, because they don't understand that the world once did not have cell phones, and the world once worked with payphones. And when I was on call, I knew where every payphone was in the city of Pine Bluff, Arkansas, so that if I was driving and I got a call, or a page rather, that I needed to call Mrs. Jones, I could stop at the Burger King because I knew there was a cell phone at the Burger King. And of course, you don't have to do that. Now here we are 30 years later or so, and it's almost inconceivable to think that anyone with whom we speak won't have a cell phone. I believe that that's going to be the situation with telemedicine as well. Next point. And I think you should become involved. Next point. And my couple of pieces of advice. The first one is to pick one project and do it well. And if I can enlarge upon that point from a more of a 30,000-foot view, don't get your project siloed. Don't have one part of the children's hospital doing a project on autism and have the ER docs using a different staff to do their ER work and on with the various subspecialties. You need to have one person in charge of telemedicine, a director of telemedicine, who takes care of all the telemedical needs at whatever institution you're at, so that your autism group can use the tools that are being used by the other group, whether it's the IT backup, whether it's units put into ERs or doctors' offices. And so that if Dr. Jones has a telemedical unit in his office and is being used to follow up on the patients with cystic fibrosis, that same unit can be used to follow up children with autism. But of course, if you're in one silo and the pulmonologists are in another silo, you don't know where the units are, and you can't play well in the sand pile together. And there may be one more point. Oh, and then expand as your patient's needs and your own demands. So pick something relatively small, pick one project, get it off the ground, and as the patients inform you of your needs, and as you see things that need expanding upon and other ways that you can get your expertise out to where it's really needed, you can make that happen and build on your earlier success with a small project. And I think that may be the end. Let's see if there's another slide at the point. No, I believe that's it.
Yep,
and
that's it.
So do we have any questions or anything that I can help with?
We do have a couple minutes if anyone has any questions for Dr. Burke that they'd like to ask over the phone, or that they'd like to type into the questions panel. We don't have any questions right now, but folks certainly might have some as we wrap up.
Well, you know the shortest book of all time, don't you? It's Humble Doctors I Have Known. And if there are no questions, then I'm going to assume that I did such a marvelous job that no one had any educational needs that were unmet. That seems unlikely.
That's an excellent point. Thanks very much, Dr. Burke. A wonderful presentation and some very important points that were made there. As you mentioned earlier in your presentation, there is a Project ECHO that has been used for across a variety of different medical conditions, and we are using it, piloting it in our network for providing teleconsultation, and planning to expand that over the next year or two. And then on the more behavior management side of things, parent-child interaction therapy, or PCIT, is another area that is now starting to become more common in the area of autism and children with developmental delays and behavioral issues. For those of you who know about PCIT, the training goes on and the therapist is typically not in the room but is communicating with the parent who is in the room with the child. Well, typically that therapist is just a few feet away in the next room, but with modern technologies they could also be a couple of 100 miles away and be just as effective. So this really does open a lot of new opportunities for us, and as his second bullet on this slide shows, we're really limited by our imaginations and thinking too much within the box. So I hope people are thinking about new ways they might be able to use this technology. Are there any other questions that might have popped up, Audrey?
No, there aren't, but I'm happy to connect folks with Dr. Burke if there are questions that come up after the presentation.
Oh, please do. Everyone, please share my email address with anyone who wants, and we can share phone numbers and talk. I do that kind of thing all the time, and I would be happy to speak with anyone.
Yes, I mean, I'm happy to make that connection for anyone who would like it. My email address will be on any of the correspondence from the GoToWebinar session.
That would be great. Well, I want to thank again our presenter today, Dr. Bryan Burke from the University of Arkansas for Health Sciences, and for Audrey for organizing all of this. I want to thank all of you who were able to sign in today, and I hope that everyone has a wonderful and productive week. Bye, folks.
All right. Thank you for the invitation.
Yes.
Bye.
Bye.